Welcome, everyone. This is Dr. Jaitly from New York on your favorite source, MuniMeterHealth, which is also your source for enhancing patient education and spreading the human heart awareness across the globe. So, welcome again. Thank you for being associating with us in large numbers and larger numbers each time whenever I come back here. So I'd like to introduce you another new subject, but before I do that, first things first, as always, my housekeeping begins. And that's number one is if you're having an emergency, of course, call for an ambulance right away. If you're in the United States, dial 911 or go to the nearest hospital or see the doctor emergently, number one. Two, for the medical students, I always advise this is not a syllabus. This is a supplement to your syllabus. So please stick to your syllabi and also to your texts that have been advised by the universities, and use this as a supplement. No question about that. And three, it's not a treatment or in any shape or form an advice. It's primarily an educational tool. So having said that, now let's delve into the subject matter, as I always say. And the matter of the subject today is sickle cell disease and its effects on the heart. In future, we're going to be calling it as SCD. And what are the effects on the heart? Obviously, we'd like to see that because this being the heart channel, we'd like to see what sickle cell disease is. Essentially, understand that the red cells, they contain the hemoglobin. Now, red cells are kind of a little disc-shaped, if you will, with an inundation in the middle. The hemoglobin sits here, and that's what makes the red cell looking red. And primarily it looks red beyond, or more so because the oxygen gets attached to the hemoglobin. It has an affinity to it. So the oxyhemoglobin makes the red cell really looking more red. Okay, so having defined that, now in sickle cell what's happening is, without delving into much details, there is one molecule which is an amino acid, and that is actually polymerized. And because that's polymerized, that sends the cell into a more of rigidity. So it is the polymerized hemoglobin, which is the sickle cell hemoglobin. We call it SC hemoglobin, if you will. That sickle cell hemoglobin is making the red cell more rigid, if you will. And it's a rigid cell which has problems going through the microvasculature, or each time in the cells, because remember, these are micron thick or thin, if you will, structures which are passing through the capillaries. Now, what are capillaries? Quickly defining those. Let's show that as an arterial here, for instance, and of course we'll show the vein as vein in the blue here. That will be the venule, and the capillaries will show in a slightly different color, obviously. And when you do these capillaries like this, you'll see these capillaries are intermingling all over the place, and primarily, basically, they are small little structures which can only allow barely maybe a red cell to pass through, and that's where the oxygen exchange is occurring at the tissue level, this being the tissue. So what is happening is the tissue is uptaking the PO2, which is the partial pressure of oxygen, and that is being transmitted through the arterial, this being the arterial, this being the venous end, and these are the capillaries. So what is happening is the PO2 is now being uptaken by the tissues, and in return, the tissue is sending the PCO2, which is the partial pressure of the CO2. So that is being exchanged back into the capillaries. Now, that's the normal phenomenon. But when you have a red cell, which is now sickle cell, and in that setting, we'll show this as a color here, for instance, and this becomes more sickle, if you will, like this. And that's why we call it sickle, because it's more sickle shaped. So when the cells are now passing through through the capillaries, if you will, they tend not to pass through because they're very rigid, and they tend to obstruct. So it's called microvascular obstruction that begins to occur. As a result, there is a microvascular dysfunction. Now, what will immediately happen? Patients will start to accumulate more CO2 in the tissues, and that's very and toxic substances as well. So that makes the tissue looks feel very toxic and painful, and the pain stimuli will begin here, as well as they are hypoxic. Why? Because the oxygen is not being taken up by the tissues because of these cells now obstructing the microvascular. There's no free flow, so the flow is getting minimized. The flow that was originally, which was very powerful, now it's only very small, minimal. And through the tissues we are talking about, and all microvascular beds, from coronaries to cerebrovascular to the to the splanchnic system, to the musculoskeletal system, wherever you think the capillaries are, and they're existing everywhere, as you know, throughout the human body. So all these capillaries, microvascular areas will suffer. So sickle cell, I consider this as a microvascular disease in a setting, if I'm looking at it from the cardiovascular point of view, because that's where the whole pathophysiology is. Because now we are starting to understand that sickle cell disease patients, they are not living only up to the teens. Those days are gone. That was 50 years ago. Now people are living to the age of 40 to 60. And along comes the cardiac effects after the sickle cell disease has been treated, or has, people are, because the patients are living longer now. So the whole idea is that even though we have achieved a great deal of longevity in sickle cell patients, but the fact is that now the effects on the heart are being analyzed and they're being recognized. So coming back to the subject here, so the capillaries are showing microvascular disease, and as a result, now one may see in the brain, for instance, one may start to show signs of CVA. Patients can have strokes. Young patients can have stroke. They can have hypoxia as a result, and sometimes a reversible stroke, or sometimes an irreversible stroke. A reversible stroke is also called a TIA, as you know. In the heart, obviously, patients will start to have acute chest syndrome, we call it. In the renal vasculature, patients can go into acute renal failure as a result. And in the tissues, musculoskeletal tissues, there'll be tremendous pain. There might be sometimes myolysis, and as a result, these patients also can have rhabdomyolysis, etc., from these manifestations. So, and splanchnic circulations also suffer. As a result, they may have abdominal pain, nausea, vomiting. So all of these things can develop, and microvasculature disease is very prevalent in sickle cell crisis, if you will. So coming back to the clinical features as to how it manifests, one is sickle cell crisis. I'm sure that's been well defined by the hematologist, but just so that you know, all these manifestations we just talked about could encompass sickle cell crisis. Acute chest syndrome is one of the areas which I think certainly deserves a little more further mention, because these patients either present with chest pain, they will present with dyspnea on exertion, they will have profound fatigue, and they may have palpitations. Sometimes they may present with arrhythmias. So just be mindful of these cardiovascular symptoms in the setting of sickle cell disease, specifically so because acute chest syndrome is and many of these symptoms are also related to the lung. Remember, the lung is also suffering, and as a result, patients can develop pulmonary hypertension and thromboembolic phenomenon as well. So the lungs, again, lungs contain capillaries, as you know. That's where the gaseous exchange classically is occurring, because there the CO2 is being sent into the bronchioles to exhale out, and oxygen is being taken up by the pulmonary venules, if you will, and brought back into the left atrium. So having understood that level of circulation, we now understand what ACS is. Now remember, there are some some cardiac effects that we are concerned about, which are very, very prevalent. One is, remember, because these patients develop a great deal of anemia because the hemoglobin is down, there's a hypoxia, and so as a result, these patients tend to compensate by increasing their cardiac output. So the cardiac output increases, and these patients can go into heart failure, and we call it preserved ejection fraction heart failure. So HFpEF, heart failure with preserved ejection fraction. So that's called heart. And the other variety is, of course, HFrEF, which is heart failure reduced EF. Okay, but here it's mostly the cardiac output that's increased. And it could be increased 3 to 4x, if you will. Normal cardiac output is about 5.5 liters. So you can imagine it can anywhere go between 15 to 20 liters. And that's a very, very demanding cardiac output, if you will, on a patient, because he or she is wanting to meet the necessary requirements for oxygenation to the tissues. The other features are rarely a myocardial infarction can occur. Invariably, there is pulmonary artery pressures. They start to rise, and that is being recognized more often now. They have been doing it for a long time, but the fact is now we have an easy availability of an echo, so non-invasively, quickly, PAP can be measured just by the TR velocity. In fact, the TR velocity has been now linked that it is directly proportional to patients' morbidity and mortality, because now they're starting to look at tricuspid velocity. If it tends to increase on serial echoes, that means these patients are becoming more sicker. Right heart failures can develop. Diastolic dysfunctions have been defined. So these are all the features of cardiovascular, if you will, manifestations of sickle cell disease, and not only just from the crisis alone. Now remember, sickle cell trait, now that tends to be very protective. The good news is there, we have some good news also, and that sickle cell trait tends to stay. There is no heart failure in those patients because these patients don't develop heart failure. And so that's a very, very good news here. Now, let's understand what's going on truly in an echo. Now, in an echo, if you were to look at, obviously the four-chamber apical will look like this. And when this is the inverse appearance of the heart here in the four-chamber apical, four-apical we call it. And so this being the right side and this being the left side, and you have the aorta here, and this is where the outflow tract is. So the blood is going in this direction. This is left atrium to left ventricle and the right atrium to right ventricle here. So invariably it is the tricuspid velocity, and that will be assessed here because this is where the tricuspid velocity will occur. And when that occurs, obviously this is where the TR will appear, and the TR should be measured in this fashion, in the Doppler fashion like this, and it's almost a tongue-shaped systolic. It goes like that. You know, it's timed well with the QRS, if you will, if you were to time it with the EKG. So this TR velocity, which is measured in meters per second on an echo, and it's about 3 meters or 4 meters depending upon the severity of the TR, that will translate into the right ventricular systolic pressure. So basically what you're looking at is you look at this velocity, make it V square, and then times 4 will give you the pressure gradient across the RA to from RV to RA. So this being the RV and this being the RA. So the pressure gradient is, we call it pressure gradient, which is 4V square. So 4, and say the velocity was 4 meters. So we're looking at 4 times 4 times 4, which is roughly 64. And 64 millimeters mercury is the pressure gradient across. So that's considered as pulmonary arterial pressure, which is very, very high because right ventricular pressure is pretty much the pulmonary arterial pressure. Now, if you add the right arterial pressure to this, that becomes truly the pulmonary arterial pressure here as well, because you're adding the right atrial pressure, which is normally about 10 to 15 depending upon what the IVC compressibility is, and we have dealt with that on a different video. So, you know, essentially we know that the pulmonary arterial pressures are elevated, and therefore that leads into right heart failure. Diastolic dysfunctions are prevalent. High cardiac output failure sets in. Stroke volumes are in general very high, and that's because of the increased heart rate, increased output. Ejection fraction is also high because the ejection fraction is preserved, if you will. Here the EF is well preserved, so it's not a problem. And stroke volumes are high, heart rate is high because of the anemia, and obviously the cardiac output is high. The blood pressure in some individuals can be also high, so they can be in a hypertensive state. Now quickly, let's go over what are the other modalities that you can really use here non-invasively. Cardiac MRI. One tend to use the BNP blood studies. This is in the blood, obviously. And that'll be very prognostic because that'll define what the kind of a heart failure we're looking at. But cardiac MRI will tell you also about the myocardial fibrosis, because many of these patients, and fibrosis has been linked to mortality and morbidity. So cardiac MRI is one of the areas. Pulmonary arterial pressure and the right heart failure sets in, and that also is very, very correlatable with the morbidity and mortality in these patients. On the contrary, sometimes I say that if the echo is clean, then you have a very echo is normal in a patient with sickle cell disease. The prognosis is excellent, by the way. So, you know, so just remember that you have an excellent prognosis in these individuals who have sickle cell disease and an echo which is normal. But you should do an echo serially at least once a year, twice a year. And of course, each time, God forbid, these patients go into sickle cell disease crisis, etc. Okay, so having defined these being the studies, now the only treatment that's unfortunately that's available for us is hydroxyurea, and I always define that here. And one is hydroxyurea, we call it. That has been approved for a long time, and people have used this hydroxyurea. And recently now FDA just approved another drug called l-glutamine. And l-glutamine, which is also called Andrea, and That's a drug which is also tends to prevent the sickle cell from sickling. So it's very important. There are only two drugs by the FDA which have been approved. Other investigational drugs are investigational procedures, I should say, which are under investigations right now, and they probably hold a great future. In the next 10 years, you're going to hear a great deal about that. And one is cardiac transplantation. Another one is stem cell, if you will, stem cell transplantation. Gene editing is coming up. They are trying to look at how they can edit the gene so that the future generations may not develop sickle cell disease. So all of these are great techniques that are being, and then bone marrow transplantation as well has a huge role. So cardiac transplantation, stem cell transplantation, gene editing, and bone marrow transplantation. These are some of the future, if you will, the investigational, research areas where sickle cell treatment policies and strategies will be probably dictated in the next decade or so, in the current decade also. So having defined this, I would like to sum up here by saying that sickle cell disease patients are living longer. However, they are now showing great effects on the heart because they are living longer, one starts to see cardiovascular effects, and primarily it's all related to high output failure, anemia, hypoxia, and of course the sickling crisis each time it's precipitated from hypoxia or infections or what have you. Now, one other thing quickly I want to mention is commonly for analgesia, because these patients are tremendously in pain because of the tissue being involved. When they get methadone as a treatment, the methadone tends to prolong the QT, remember that. And if the QT gets prolonged, you can end up into torsade. And these patients, when they get torsade, that's where the issues arise. So just be mindful that methadone prolongs the QT. And specifically so, torsade could be a lethal arrhythmia in patients and has contributed greatly to a fatality in some of these individuals who are on methadone chronically and the QT is not being monitored. So just be careful that the drug interactions, especially with beta blockers or calcium blockers, if they're already on, these patients are, you have to be very cautious when you're combining them with methadone because the QT prolongation can occur in these individuals. Okay? So that's a nutshell in sickle cell disease. I just wanted to give you in this short video vignette, and hoping to meet you again on the next video, which will be again exciting hopefully, and we'll pick up some nice subjects for you. So this way you can quickly brush up before you take the exams or before you go in for your tutorials or examine a patient. So you have more clips and more tips for yourself. And I thank you again for associating with MuniMeterHealth, your favorite site for education, both for patient education as well as for clinical education, because that's my deepest initiative right now that I want to put in this video format to improve the clinical outcomes in my patients, okay, and your patients. Thank you again for watching. This is Dr. Jaitly. So long, and see you in the next video.